Okay, so we're getting almost to about 100 participants, and I'm sure that they'll continue to come in. I'm just going to start by introducing our faculty and going over tonight's topic. Proximal humerus fracture is such a broad topic with many technical issues and questions. We're going to specifically talk about open reduction tonal fixation versus replacement, and kind of giving a little bit more attention to the arthroplasty portion, because I think a lot of times with the techniques that we've come along with fixation, this can kind of get off to the wayside. My faculty tonight are Dr. Hobie Summers from Chicago, Chief of Orthopedic Trauma. Pleasure to have him here tonight with his great expertise in this type of injury. And I'm also joined by Dr. Jonah Davies from Seattle. He's out of Harborview. And he has extensive experience with not only fixing these, but also replacing them. And of course, I'm from Toronto, Ontario, and from Sunnybrook Health Sciences Center, and also love fixing and talking about proximal humerus fractures. Now, I'm just going to get a little bit of the housekeeping out of the way. These are our disclosures. Just a reminder for Zoom, I know everybody is very experienced with this, but please have your microphones muted and your video cameras off. Tonight, we're going to be using the Q&A function. It's not going to be the chat, but it's the Q&A. Please submit your questions, and I encourage you to ask all of your any question regarding technique or in general cases. What I will do is review the questions with our faculty and then try to get to as many as we can tonight. Overall, tonight's agenda will be just proceeding on with cases that represent. We're going to start off with Dr. Summers doing open reduction tonal fixation indications, and then just follow that into arthroplasty with Dr. Davies with some choice cases there. And then the Fireside provides a unique opportunity to discuss a paper, and we've chosen a randomized control trial on proximal humerus fractures that compare open reduction tonal fixation to reverse shoulder arthroplasty, and we'll have time at the end to review that, and again to just wrap up in the last few minutes. And I hope to have everyone out of here about 9:25. So overall, the learning objectives tonight are really to go over, when do you want to fix these? You know, I think this is still a question that's very ambiguous for a lot of us, and really the literature is kind of always evolving. So it's a moving target for us. And tonight, I hope we can provide some clarity. And then, of course, indications for arthroplasty. We know that in the elderly patients, this is an option that we are considering more and more. And hopefully, Dr. Davies and Dr. Hope Summers and I can shed a little bit more light on that. The key thing here is really whatever we do, it's going to be the technical aspects as surgeons. How do we reduce it? How do we position the implants? And of course, in shoulder, it's going to be how do we manage the rotator cuff and the tuberosities? So without any further delay, I'd like to start off with some cases and turn the presentation over to Dr. Summers.
Well, good evening. I'm going to talk a little bit about fixing. So for indications, who should receive open reduction and tonal fixation? So I think that takes a serious assessment of the patient, a serious assessment of the fracture, what the patient's goals and expectations are. And I always think about being able to get your hand on top of your head. So the vast majority of the patients I see with these are older patients, not necessarily elderly, but I try to talk to them about what their goals are. I think the goal of being able to get your hand on top of your head, to be able to externally rotate that far so that your elbow is not in your line of vision, is a pretty good goal if we fix these for older folks. Most people are pretty happy if they can do that. That's enough forward elevation for them to be functional. So really go through goals and expectations when you talk to patients about fixing them, treating them non-operatively, and arthroplasty as well. So in terms of age, I know there's a lot of age cutoffs with a lot of these things, and I think it's a physiologic age. I have 70-year-old patients that still ski and do martial arts, and I have some 55-year-old patients that are not terribly healthy. What's their cognitive status? Can they participate in rehab? I think that's a very important determination of patients that we choose to operate on. Their activity level, what their needs and expectations are, and then also what their bone quality is like. If I'm going to repair this fracture, is it going to be bone quality that's going to stay together and heal for me and not fail? So I divide these into two groups: high energy injuries in young patients. You'll see open fractures, fracture dislocations. These are typically high functioning young individuals. They're typically displaced, sometimes comminuted, unstable patterns, but these patients have good bone quality. So in young high energy patterns, for me, the goal is to restore their anatomy and their function, try to preserve the humeral head, really focus on tuberosity position, as well as hardware position to avoid impingement and try to maximize their cuff function. In the older patients that are lower demand, I want to maximize their function and alleviate pain. So I want to try to get them the best function I can if I'm going to repair it. These are very common osteoporotic fractures. So they commonly have poor bone quality, and we know from the literature, even if you treat them non-operatively, they do better sometimes the sooner you get them in therapy. So within 2 weeks, you want to get them moving a little bit. It's difficult to get a good reduction, maintain a good reduction, and then get a good functional outcome in this group specifically. So non-operative treatment for the elderly, I would say probably 75% of these, I think we can treat non-operatively. There's a lot of them that are minimally displaced. Seniors that are in their 70s, 80s, 90s, they have limited functional demands. Some of them can't do rehab, they can't participate in therapy, or they're poor surgical candidates. This particular fracture pattern, I think, is one that if folks looked at this, I would suggest to you that in the older population, this is the perfect fracture to treat non-operatively. These typically stay put, they do well, people function well. So these kind of slightly valgus impacted fractures, the tuberosity is not significantly displaced. This is a non-operative treatment all day long for me for the elderly population, and they're quite common actually. So what's the controversy about open reduction internal fixation? So there is some literature against fixing these for low energy fracture patterns. There's variable results with locked plating. There's some reports with high complication rates. There are some reports where people don't have as many complications. So there's kind of a mixed bag of results when it comes to plating these fractures. The quality of reduction has not been a focus in the literature, which would be, for me, what makes it controversial in some of the statements that have been said that we really shouldn't be fixing any of these low energy fractures in the elderly population. I think I've found maybe 3 or 4 articles that talk about quality of reduction. And a lot of times it's in terms of failure, not necessarily in terms of their ultimate outcome, but it has not been a focus in the literature. So operative indications, all displaced fractures in young, healthy, active people, for me, is an operative indication to fix these. Physiologically young and active seniors is where it gets a little confusing. Displaced and young are subjective terms and requires judgment. I think measuring 5 millimeters of displacement of a tuberosity on a plain x-ray is very hard to do on a 3-dimensional structure like the proximal humerus. So these are a little subjective to me. For me personally, my indications, and I know this is not in cement, but displaced fractures in a patient that I can obtain and maintain a good reduction. So if I'm convinced that they have a fracture that would benefit from surgery because it's displaced, they have bone quality such that if I obtain a good reduction, I can maintain that reduction. Patients that can participate in rehab, I think if I do a good operation and they don't go to rehab, they don't get therapy, I don't think their outcome is going to be that good. That's been my experience. Patients that can tolerate a surgery, there are some folks that are just too high risk for surgery and it's not a great idea. And then I also consider those that have functional demands worthy of an operation. So sometimes I'll see someone in my office that has proximal humerus fracture. I'm trying to get to know them. I'm trying to understand what their goals are. Sometimes I'll let them go for another week, come back and see me again, talk to them again, and really kind of understand what their demands are and what they're trying to get out of their treatment. They really participate in this decision with me. So now I want to talk a little bit about reduction techniques to try to minimize failures. Failures of fixation is a big part of the literature why folks think that maybe we shouldn't fix a lot of these, especially in the elderly population. So for me, I would like you to come up with a strategy to approach these fractures consistently. If you have a consistent approach, this is the order in which I do things. This is the stepwise approach I have to treating these fractures. I think that can go a long way to helping make these things easier to fix. I think they're very hard fractures to fix. I would hate to show the x-rays of the first 20 that I fixed, but the last 20 I would be happy to show. So I think this really takes a strategy and approach to really get consistent, good reduction in fixation with these fractures. So
Hobie, before you go over that, there's a question in the chat. Just goes back to your indications. It says you don't have to go backwards. Just that does the use of ambulatory devices, so someone's walker dependent or wheelchair dependent, does that sway your decision one way or the other?
Not necessarily, because there are some patients that are walker dependent that really need that arm to use their walker. I may tell them, I'm not going to let you use your walker for a little while after I fix it, but because I want to try to maintain their ability to use that arm, I may keep them off of their walker for a little while, but I have fixed patients that need that arm to use their walker. I'm not going to leave them with the displaced fracture. So yeah, I have fixed patients that use walkers, absolutely.
And then this is a question from me because I'm interested. You say failure to be able to do rehab, but sometimes I find patients can't do rehab with non-operative management because if there's pain or there's motion, and those are actually for me an indication to fix them. Like, because I like to be active with my non-operative management, not just no management. So I send them to early therapy, and when they're having too much pain, sometimes you fix them and all of a sudden they can move more. So I don't know what your feeling is about that.
I guess what I'm saying is patients that have perhaps a fracture that's displaced, but will most likely heal on its own if I don't intervene, right? It will probably still heal even if I don't do anything. So in my mind, I would love to get them in therapy, even if it's not going to heal. But am I going to do a big operation on someone that maybe won't benefit from that reduction in that big surgery if they can't rehab it appropriately afterwards? I would agree with you. Even my non-operative patients, I get them in therapy early. I think that's the best way to get a good outcome, is to get them moving. But I guess that's what I mean by rehab potential.
Yeah, totally agree.
Yeah, I agree as well, Jonah, on your point about, really directing treatment so that you can increase mobility, just like we do for hip fractures. And so I will consider all of those factors as well, especially if I feel that it's going to provide more immediate stability so they can get going.
So for me, the things that I'm thinking about, like, what are my goals of this operation overall? So I want to align the medial head to the medial shaft. That is a critical part of achieving a good outcome, I think. You got to get the medial head aligned to the medial shaft to the best of your ability. Correct varus valgus, which is, I think, what is most commonly focused on, because it's the easiest x-ray to interpret. But I think your sagittal plane alignment is also important, particularly in terms of failures, and really understanding your sagittal plane alignment in terms of achieving length, getting your length back and getting the proximal humerus where it really belongs. I like to use K wires from the anterior shaft to the posterior head, and that is one of the reduction techniques that I really try to stress to people. If you can get your wires completely out of the way, your provisional fixation completely out of the way of where you're going to place your plate, you're not removing wires to place your hardware. So getting your provisional fixation, once you have a good reduction, in a good, safe place that allows you to do your definitive fixation very easily is to me paramount. And then reducing and securing the tuberosity. So a lot of times we use suture. Sometimes the greater tuberosity will be actually under the plate if it's a big enough piece, and you'll actually get some fixation that way. But don't forget that sometimes you can use screws. A large, lesser tuberosity fragment can be very amenable to screw fixation if it's a big enough piece. So don't think that you always have to use only sutures. Sometimes you can get a screw in there. And then I determine if they need augmentation. So some of the valgus impacted fractures in particular, when you reduce it, they'll have this just huge hole where the whole head is just crushed. And I think using a fibula, calcium phosphate cement, augmentation that will help keep that head in position, I think is something you really have to think about if you want to minimize failures. And then plate fixation, where the screws should be, and the depth of those screws, I think, is important. There's been plenty of literature on where the screws should be, and perhaps some that may actually be too long. So for me, position and imaging, there's no right way or wrong way to do this. I think there's a lot of different ways people position patients, but this is a ProFX table with a diving board. It's just a radiolucent table that we happen to have at our hospital. I bring the C-arm in from the head of the table, and when I position the patient, I have them on that plexiglass board so I can get an AP and an axillary view without moving the arm. So for me, it's nice to keep the arm in one position rather than moving it to get my images. I move the C-arm, and I think that for me is very helpful, especially when you have an unstable fracture, and that's what it looks like draped out. And that's the way I like to position. I think it can be done in beach chair. It's unfamiliar to me, and that's why I don't use it.
Hobie and Jonah, just a quick question from the participant regarding, it's from Dr. Trenholm. It's regarding fibular strut for the allograft or the bone graft that we use to fill that void especially when you mentioned, Hobie, about elevating a valgus impacted one and you have that big space. What's your experience with fibular struts and trying to remove them if you have to revise it later? Is your experience that it heals really well and it's a challenge, or they're not well incorporated? Joan, I'll ask you first. What's been your experience with fibular struts?
Typically, either it doesn't heal, in which case easy, just pull it out and you're done. If it has healed, I've actually cemented or done an arthroplasty through the canal of the fibula. So just kind of reamed up. You just take a drill and like a 3-5 drill, I drill through the intramedullary canal of the fibula, and then I use my opening reamer for the canal, and then I'm able to do it. And I actually have a couple that I've just put in through the fibula or carved out enough hole that the fibula breaks and then pull it out. So there's various techniques, but I'd say it's about 50-50. Either the fibula doesn't heal, which is partially why the fracture failed, or if it does heal, I'm able to do through that. It's a big deal at a lot of meetings when people talk about arthroplasty, but it hasn't been a big deal for me.
I don't do arthroplasty, and I've not had to revise one that was fixed that way. I would say my arthroplasty partners would complain that if the fibula goes way down the shaft and it heals in the shaft and it's really blocking the shaft, it can be difficult to deal with. I think, there's a lot of techniques that people use with the fibula where they use a much shorter fibula. It doesn't go all the way down the shaft. It doesn't fill up the canal. So I think there are techniques you can do to avoid making a future arthroplasty a real problem. So let's move on with the case. So this is a patient with a displaced proximal humerus fracture. And I chose this one simply because I try to go through a lot of different reduction techniques to try to get the head shaft alignment appropriate. Let's put it that way. So by the time we get to the operating room, this is what it looks like. It's displaced. It's very short. It's rotated around the back. Not an uncommon scenario. I think the lesser tuberosity is still attached to the head, which I think makes things easier. I think the greater is probably a separate fragment, but not super displaced. So just going through different ways of trying to reduce this. So I said that the medial head needs to be reduced to the medial shaft. There's a bald spike pusher here, but I'm not really pushing on the head. The head's only going to go so far. The acromion and the glenoid, you can't really push on the head. You don't want to just destroy the head by pushing. So what I'm doing is I'm trying to stabilize the head and then pull traction on the distal fragment and see if I can easily realign them. Other things you can do, because I think this is a real problem, is not getting it reduced in the sagittal plane. So sometimes a small Homan that you can put in the fracture site, you can get it on the head, apply traction to the shaft at the same time while levering against the shaft, can help you kind of move the head shaft relationship where it really should be. Things like a lamina spreader. Sometimes once you get it aligned or get it close, you could use a lamina spreader. You're not really cranking on this. You're trying to just get it to help hold things still. Get the shaft out to length and then make it stay there. Try to provide some way. You can see the enormous hole that is in the center of this now because it's so impacted. Getting that to stay there is going to be really hard. So a lamina spreader can sometimes be actually quite helpful to just help hold it in the right position.
Hobie, are you doing this with all of the techniques that you're using? Can you do that through both a delto pec, or do you have to do it through a split? What's your preferred approach? It's one of the questions that's coming up.
Preferred approach. You know, it's interesting. I go back and forth. So I have friends that do all of these through an anterolateral acromial approach. I have friends that do all of these through a deltopectoral approach. For me, I would say it depends. These techniques you could do through either approach because I'm essentially working through the fracture site. So I think you could do it through either approach. With that being said, I think delto-pec for me, the more complicated it is, I'm more familiar with that approach, and I typically will use a delto-pec the more complicated the fracture. Those fractures that are two parts or a two-part fracture with a big greater tuberosity that's really displaced, or the isolated greater tuberosity that's displaced, I like to use the deltoid splitting approach for those. So I go back and forth a little bit, but for me, when it's a really hard one, I typically do a delto-pec.
Quick question, Hobie. If people on the call wanted to try to start using a deltoid split, what fracture pattern would you recommend other than a non-displaced two-part to start with a lateral approach?
So I think an isolated displaced greater tuberosity fracture is a great one to start with because you only have to focus on one fragment. And when it's really displaced and it goes around posteriorly, you can see how much easier it is to get to that fragment through a deltoid split approach. So that would be one that I would start with, or a relatively straightforward two-part fracture would be the other one that I would start with, and kind of figure out what you can see, where you can get, how much easier it is actually to apply your plate. You have to deal with the axillary nerve. Well, boy, you're right there where you want to place your plate. It's just figuring out how to get to the other parts of the fracture to deal with it is what you learn from that. Yeah.
I think for me, the three-part valgus impacted is the perfect case for the deltoid split because you're right where the defect is and you can see the greater. So you can elevate the head, put the greater back, and put the plate on where it belongs. So I really like that. I noticed I do positioning the exact same way you do, maybe from the fact that we both are from the same fellowship, but I've actually gone to using an arm positioner 100% of the time. I think that one of the questions was, do we have help in the OR? And we're lucky we work in places that have a lot of residents and fellows and medical students. So there's always someone to help hold retractors. But I found, and maybe Diane, you have experience because of the arthroplasty, but arm positioner, distal, holding the arm forward elevated, corrects 90% of the sagittal plane deformity. And it holds it there much better than, unfortunately, a medical student or a resident or a bunch of bumps and where the arm keeps falling. So I've gone to that 100%. And I would say most of my partners have stolen my technique now. And so I don't know, Diane, do you use arm position at all?
I totally do. So I used to do a lot of the proximal humerus fractures, supine on the Jackson, just because they're poly-traumatized usually at our center. And we're just trying to knock off as many operations at once. But when you have them supine, you definitely need another assist, just to hold the arm forward elevated, just like you mentioned, because it wants to extend, and that's not the position we want. So I prefer now going to beach chair. You can get good images, and I always use an arm positioner. And at our institution, we have a spider. And it really does help cut down on the number of assists and really get you ideal positioning, not only for images, but when you're just trying to get those tuberosities down and you don't have another hand, the spider is key.
Yeah, and you can use it beach chair, but like I said, I use it supine. And if Hobie, if you don't, I would say go and steal it from Dr. Salazar in his room, and it's really really helpful.
It's funny. I did a proximal humerus fracture today, and I talked to the nurses about, I need to start using this spider because all my friends are using it, and it's got to make things easier for me. I really want to start using it. And the drape for the spider is on back order, so I didn't even try it today, but I am going to start trying to use it for sure.
It's super helpful.
Yeah.
Supine or a beach chair.
Yeah. Okay, so then a little more complicated. Now I have a lamina spreader, I have a shoulder hook, I have a bald spike pusher here. So I know it looks a little crazy, but this is super unstable. This thing is going to basically just barely teeter on that medial edge once I get it there, but I got to get it there. So I'm using the lamina spreader to try to help maintain the length that I have. I'm using the ball spike pusher to kind of hold the humeral head in place, and then the shoulder hook to try to manipulate the shaft around the humeral head and get the head shaft relationship correct. With that being said, I'm going to go back to my small Hohmann retractor. Then now I'm going to try to lever the shaft into position. I can turn this around and then try to just push on the head. That didn't work. I have a small, just flat osteotome. It kind of went in there a little bit easier. And as I push and still use my lamina spreader, I can finally get that medial side to line up. I'm getting the lamina spreader to help me maintain that length. And I think I'm finally getting the medial side of the head lined up with the medial side of the shaft with an enormous hole in the middle. Once I get that there, I want some provisional K wires. So these will go from anterior shafts, hopefully, or if you just need to get any wires in at all to begin with, you can go from lateral to medial, that's fine. Get something to hold this still. You can always move your wires around, but I prefer them to be anterior shafts into the posterior head and stay out of the way of my fixation. So here you can see the wires are going from anterior shaft, posterior head. I don't have my length completely perfect here. With a couple of wires in place, I can still move this a little bit. This is not absolutely stable yet. So I'm going to try to keep the relationship that I have on the AP image and work on my sagittal plane after that and try to improve my reduction a little bit. So with only a couple wires in place, you still have the ability to kind of overpower those wires, fine tune your reduction, and then add more.
Hobie, do you find that putting the cuff sutures in helps to get some control of the head? Because sometimes when you're just dealing with this ball and, before you can get your wires in?
Yeah, so cuff sutures are step one. That's just part of my surgical approach. So I don't try to start reducing any of this until I have sutures in the cuff, because it helps me with rotation, it helps me move the head, it helps me control the head, even if you just hang on to them and manipulate the shaft around it. So perhaps I left that out, but sutures in the cuff for me is just part of my surgical approach. I typically use number 2 ethibonds. It's just what I've used for a long time. They fit through the holes in the plate really well. What do you guys like to use for suture for the cuff?
Or it's any kind of hi-fi, something very strong so I don't end up breaking it at the key moment.
I actually put just an O polysor, for temporary, for manipulation, and then definitive, I use a non-absorbable braided number 5. I use a bigger suture. There's a study out of forget where, but for arthroplasty that showed they actually cultured the tag stitches at the end of a case, and they always had C. acnes in it. So I always replace the tag stitches right before I'm going to do the definitive fixation of the tuberosity.
Good to know.
Yeah.
So I was saying you can overpower 2 wires and then add more once you think you have your sagittal plane reduction a little bit better. I know that looks like a ton of wires. It is. It's a huge hole. I'm trying to hold this little shell of head in good position. I don't think that's too many wires. I don't think that's crazy. I think that's pretty standard for proximal humerus fractures, at least for me. Once I get it where I want it, the last thing I want to have happen is have it fall off or move while I'm applying my definitive fixation. Here it is on the other view. Quite frequently, you'll see this cortical fragment that the shoulder hook is on, where you can actually visualize the reduction of that cortical bone from the shaft to the tuberosity fragment, even if it's comminuted. If you spend the time looking for it, a lot of times you will actually find that. And if you can get that little reduction over there to kind of validate that you have things in good position, I would say at least look and try. I'm also looking at this one saying, boy, this is something I need some augmentation. That head is going to want to fall right back on the shaft where it was. And so this is where my preference is calcium phosphate cement. That's just what I've had pretty good luck with in the past, and that's what I use. I think you
Hobie, when you don't want to, when would you accept, like you've got it perfectly out to length here. One of the questions was basically, can you actually impact and shorten this, basically putting the head on the shaft? But you do have to accept the shortening. And when would you consider that, or do you?
Yeah, so if you do that in this particular case, then the medial head is probably not going to be on the medial shaft. So you either have to be varus or valgus to fix this one short. The ones that you could potentially fix short, I would say, are the ones that have a lot of cortical comminution, where you can still set the head on the shaft correctly, but it's so comminuted that if you bring it out to length, there is no cortical contact between the head and the shaft. And in an older person, then I would potentially shorten those a little bit. But in this one, the only way I can shorten it, I would end up with deformity, unfortunately. So moving along, then I'm trying to get my plate in position, trying to make sure I get my screws in a good position. I personally like to fix the plate to the distal fragment first and kind of get my plate exactly where I want it, and then work on getting my screws in. Now, in the sagittal plane, I would argue this is where it's difficult, because it's very easy for your plate to kind of twist on you. It's easy for it to move a little bit. You want to try to get, at least in my opinion, your screws spread out in the head as much as possible. So even if it's not sitting on the shaft perfectly, but it's spread out in the head very nicely, fine. I try to get my plate sitting perfectly as best I can every case, but some of these are really hard. And so I tweaked my plate a little bit. I think I have a pretty good spread of the screws in the head. This is a valgus impacted one. I think as long as I don't drill through the head at all, before I put those screws in, I'm pretty safe. Once you have exited the head with your drill bit and you put a screw there, I don't think it's really doing much. I think it is an invitation for the head to fall back on that screw because there's nothing to stop it once you drill through. So careful drilling, making sure your screws and your drill bit do not go through the head, spreading your screws out, augmentation with a good reduction. I think this is what I'm trying to do every time I do one of these cases.
Okay, when you were trying to get that reduction, one of the questions was basically around like the girth of the K wire. I typically will use a 2.0 because I'd like something robust that will purchase a cortex on the far side so it gets some stability. What kind of K wires do you like to use? And then one of the other questions was like, how do you get the angle to put those K wires in? Like, where are you trying to get that? And ideally away from your plate construct.
So I almost always use 2.0 K wires. In young people that have really hard bone, we do have drill tipped K wires, and I will use those so I don't burn that diaphyseal bone. It is just so hard to get through that really hard diaphyseal bone in young people. So they do make drill tip K wires that work very well. At the very least, you can drill through the cortex of the shaft and then put in a regular 2.0 K wire if you want to. These K wires are all going from the anterior shaft into the posterior head. The head wants to fall off posteriorly almost always anyway. So I want as many back there to keep the head from falling off, maintaining my reduction in the front. So all of these K wires are out of the way of me putting my plate on laterally. With that being said, some of the screws that I put in may be running into those wires. Fine, pick another screw. Put as many screws in as you can without removing any wires, and then slowly start removing your wires and putting in the rest of your screws.
Great, thanks.
Did I answer all of them?
Yeah, I'm just it's just access to. I think sometimes it's very hard to get the plate onto the anterolateral surface of the proximal humerus, which is the ideal spot. So I'm just my approach oftentimes is to peel a little bit of the anterior deltoid if I need to. Usually I don't use a plate that's that long that I need to do that, but if I do, I will just elevate it. It doesn't harm the deltoid in too many ways. So, and then I just repair it back to pec on closure. Is there a technique that you use to get adequate exposure so that the plate application is easier?
I would say that I always elevate a little bit of that anterior lateral deltoid, elevate it just enough to get your plate there. If you ever come back to take a plate out of a person where they have some impingement or their plate is bothering them, that deltoid heals down very nicely. I've never had an issue with that. So I think you kind of have to take a little bit of it down. I do not take down the pec when I fix these, but a little bit of the deltoid I take down to get the plate situated. And in, to be perfectly honest, in really muscular people, if you don't take down a little bit of the deltoid, not only are you going to have a hard time getting your plate in, just being able to do everything you need to do with a really muscular person is very difficult. So I take a little bit of the deltoid down.
That's awesome. Thanks so much, Hobie.
I'll say I use a different plate now. There's another plate. There's many other plates now that exist that have the position goes a little bit less lateral, so it's just sort of just posterior to the biceps groove, and the plate angles posterior proximally and more anterior distally. So you still may have to take out a little bit of deltoid if you go long, but for a 2-hole or a 3-hole plate, it usually fits. It fits nicely there, so you're able to do that. And I use a radiolucent deltoid retractor, and I'm able to see enough posteriorly while still getting x-rays. So those are some little tricks too.
And Hobie, just a final question for screw lengths. I know we didn't talk about it that much, but do you usually like take 10 off your measurement, or how do you determine how long you want and how many? Do you have to fill out all the holes in the plate?
So I would say in young people with good bone, I don't think you need to fill all the holes, but it really depends on the fracture pattern. In the older patients, I pretty much put every screw in there. I'm doing everything I can to hold that in position. In terms of length, I'm very careful when I drill. I do not want to exit the articular surface of the humerus, because then I think that screw is largely ineffective. It can collapse right back on that screw. There's no bone to stop it. So I don't use a wire. I use a drill. I drill carefully. I typically actually read the measurement off of the drill, and I make it 2 millimeters shorter to guarantee I'm not too long and I don't go through the humeral head. That's what I do.
Perfect. Thanks so much. So just moving on now to arthroplasty options. Jonah's going to proceed with a case for us.
Is this showing up right?
Yep.
Okay, good. All right, so I'll talk about a case, and I think this is something that I see more and more of, but fairly common, and I'm sure Hobie and Diane see a lot too. So this is a 62-year-old retired teacher, fairly active as far as community ambulator, but retired, so no skydiving, no rock climbing, and fell down at home, has right shoulder pain, no other real comorbidities, and has a left total hip arthroplasty. And so here's the x-ray. And, you know, one of the things that I think about when I see this is, wow, this is a pretty bad injury with a lot of displacement. Hobie, when you look at this, what's your first sort of thought that comes through your mind?
Well, it's unfortunate that it's dislocated. And the first thought that comes to my mind is you got to be very careful getting that fragment out of there. It might be very difficult to get out. It's going to take some time. This is not going to reduce with just a traction reduction type maneuver. And I want to know what his neurovascular status is immediately.
Yeah, so this patient has normal AAIs, normal pulses, normal neurovascular status, but is sort of dislocated like this and sitting in the emergency department somewhere in Illinois for you. Yeah. I don't know where your referral center is, but for us, it's about always 2.5 hours northeast. Yeah. And then they just call us and they say, what do we do with this? Yeah. Do you have them try to reduce it?
But I probably wouldn't have them try to reduce this one. I don't think that one's going back in. That one is through the capsule. That's in so much soft tissue. I don't think that one's ever coming in. You may have, you know, one where it's not really that displaced. It's sitting right next to the glenoid. It might actually pop in with a little tug, but I would say that I don't think this one would be successful at all.
Okay, I know Diane's going to ask me a question, so I'm going to put my next slide up. So I get CTs on all proximal humerus fractures. I know one of my buddies, Mike Gardner, always makes fun of me at meetings because I get for CTs on everything, and he says that it's because I don't know how to look at x-rays. But I actually think that it gives me a lot of information. It helps me decide, you know, fix or replace sometimes. And when I fix, it helps me plan my surgery better. Now, maybe it's because I'm not as good a surgeon as Mike, but I think it does allow you to kind of look at those pieces critically and have a game plan beforehand. I know it was brought up in the chat about CTA. I typically don't get CTAs purposefully, but because of the trauma nature of our hospital, a lot of our patients get CTA chest. And I found that the artery is always sitting right next to the humeral. I don't know, has anybody ever looked at that, like Hobie or Diane? Have you seen that anecdotally?
Yeah, I've seen that. So I actually do, you know, when the head is in the axilla or a proximal spike is in the axilla, I'll have a really low threshold to do a CTA. I know that even if they have good pulses, you know, when you're in there and you're disimpacting or moving it around, you can really disrupt that because it's actually putting a plug into the vessel, and when you start to mobilize it, you could be in trouble. So if it's there, great. And I agree with you. I don't have to get on every single case, but these types of ones, I definitely would.
Yeah. So Hobie, am I overkill by getting CTs on everybody?
No, you know, I get a lot more than I used to. I think the simple patterns where I can clearly see what's going on. I know where the greater tuberosity is. I know if the lesser is attached to the head. It's a pretty straightforward one. I won't. if I'm trying to decide whether or not I'm going to send them to my arthroplasty colleague, if it's fixable, or it's complicated enough that I'm not quite sure what my strategy is going to be, I get a CT. I get them much more frequently than I used to, for sure.
Nice. So you're going to defend me with Mike in the future
Absolutely.
meetings. That'll be good.
Absolutely.
Jonah, the other thing I would totally defend for you as well is that, you know, when you're starting to fix these, you really don't know, you have to kind of have all the information, because what you see on the CT, you want to be able to see during surgery. So I find that it's also a very helpful learning tool, because sometimes you don't know what you can't see. And I'm telling you, on the CTs, there are fragments that you're going to miss. You don't know where they are. And so it's really great to have that as a backup. I think if you're somebody very experienced and you kind of already know that, that's fine. But when you're starting out, I definitely encourage that.
Yeah, I agree. I mean, I think I've been doing this about eight years now. I know I kind of look young, but I've definitely still, and I'm dual trained shoulder and elbow and trauma. And like Hobie said, these are some of the harder fractures that I treat overall, and I'm sure you guys feel similarly. And so I don't see a downside to having much more information. You know, they get CT scans on any patient who basically sneezes on their way into the hospital for us. So I don't think it's a big deal to get an extra CT scan. And it really allows me to look at a couple things. So a couple things I look at when I see this to determine fix versus replace is the size of the humeral head piece. Now, oftentimes, and you kind of glanced over it, Hobie, in your presentation, but it was such a key sentence that I'm going to tell you again. Just because you can get it reduced doesn't mean you can hold it reduced, right? So your indication was I can fix and maintain reduction, and so we can we can get reduction, but those really thin head pieces, I worry, one, about the vascular support to that, and two, about how much screw fixation I can get in those. And so those really thin headpiece starts to sway me to do a replacement much more. Now, obviously this one's dislocated. And so that's another sort of check off on that. How do you feel about comminution? Is that something that plays into part deciding fix versus replace, Diane?
Not much, not that much. I mean, you know, when there are 1,000 pieces, it's always a tougher go at reducing those fragments. But I find that my main indication for arthroplasty is primarily the head, whether it's a split or whether it's just a shell. I think most of the time I can reconstruct the tuberosities if I have a reasonable viable head. So that probably would be my priority.
What about, and maybe I'll open this to Hobie also, what about neck comminution? So those now we get a lot of high energy at our hospital, but you know, those that have a lot of comminution right at the medial calcar, you know, your whole thing was bring the medial neck in line with the medial head, but what if there's no medial neck? What if it's gone?
Yeah, so I have fixed a few of those. Primarily in younger patients that have a lot of comminution there, but they still have a really good head fragment. So I know I can still get good fixation in the head. I think those are good ones to perhaps augment with a fibula. Would be an ideal one for a fibula, right? You're going to do a cortical substitution of the medial side, particularly in a young patient, to make sure that humeral head stays there. If it's an older patient, then I'm not going to lie, I'll talk to my arthroplasty partners. I'm like, I can fix that. I don't know if it's going to stay there. And we kind of talk about it together for sure.
Yeah. So that's really what I was trying to show on this. So the things that make me think about doing an arthroplasty are, one, it was brought up in the chat, but age. Younger patients, obviously I'm not offering reverse shoulder arthroplasty. What that age cutoff is, I think, is changing. When I was a resident in Canada, it used to be, you know, if you did it under 75, you were going to go to jail. I think now at the latest meetings of ASCS and AOS, some people are recommending that, you know, these large trials be 55 and over. I think I'm a little bit shy of that. I tend to say I start considering at 60 and above. But 60 is just a number, and it really has to do more with their physiological age and what they want to do as far as activities and what they want to do for that. So that's number one. And then number two is, does it have a high risk of avascular necrosis or of displacement post-fixation? Because getting the reduction may be hard, but keeping it there is actually harder oftentimes. So the tuberosity, if it's one of those where it's a shell of a tuberosity or a bone cloud, sometimes I tell the residents that you can't really tell where the tuberosity starts and finishes. So you're basically repairing the cuff. When that head fragment is quite small, when there's a lot of comminution on the medial calcar, and if it's dislocated, that definitely increases. And if it's dislocated for a long period of time, so if this patient's in Alaska coming down to us 8 or 10 hours later or a day later, it tends to increase or sway my decision a lot more. And especially in those patients that want to have one surgery or don't want to take the chance of going back and having to take screws out or revising. So I'd say that's how I typically approach this. And I think the other thing that's important is the reverse from 20 years ago is not the reverse from today. And so although typically speaking, these patients can do a little bit worse than reverse for arthritis, overall, the large series tend to show that they do quite well. And if they have tuberosity healing and that the surgery is done correctly, these do really, really well. And it's, the problem is not so much, can you get them to do well? It's you want to make sure that you're avoiding complications. But if your complications are relatively low, I think that it's a really good surgery. I don't know, Diane, is there any other sort of indications that we missed about?
No, I think one of the key factors is always about age. And I mean, one of the questions that came up is really like, if you're considering an arthroplasty for the patient, what makes you choose a Hemi over a reverse other than age?
Yeah, I would say, patients that are super high demand, that do something like they want to weight lift and they don't want to stop, or they are actively working as construction workers at the age of 60 and they don't want to stop. Those are ones where I would think about doing a Hemi because I think that the impact on the reverse is not great. So those are the ones that if they had arthritis, we would maybe think about doing a Hemi or a remit run or something like that. I think those are those patients that I think about, that just the total demand on the shoulder.
I agree. I think, the younger the patient, and, the Hemi arthroplasty is almost a forgotten operation, but if you do a very good Hemi, it can be extremely successful. And so I think for the younger patients that are high demand, that they're going to be loading their joints and not going to really comply with the reverse restrictions, are, I think, ideal for that. And a lot of care and love have to be considered when you're going to do the Hemi arthroplasty. I think that operation in itself is probably tougher than a reverse. So a lot of tips and tricks for that is really needed.
Yeah, I'll agree. I think a Hemi is much more complicated than a reverse and has a much higher rate of complications if it's not done correctly, if that makes sense. So I think if it's less plug and play to a certain extent, although I think the reverse is complex. I just think that, and I do see a question in the chat about intraoperatively checking the cuff. And I think the important distinction is, for me, the reverse is not being done because there's a cuff issue. It's being done because there's a potential for dysfunction of the cuff. And the outcomes are much better if the cuff doesn't heal than a Hemi would be if the cuff didn't heal. And so you can still get good function out of a reverse, potentially, if the rotator cuff doesn't heal. And so it doesn't matter so much, even if there's most of the patients that end up with this fracture actually have reasonable cuff. Maybe the tendon tissue is not great, but it's present. And that's why the tuberosities peel off rather than dislocate.
Right, because remember, the tuberosity involvement is really an avulsion fracture, and you can't have an avulsion without an intact cuff. So when you see a displaced tuberosity, almost for sure that the cuff is intact. Where you see in elderly patients where they have a rotator cuff deficiency, it correlates usually without a tuberosity fracture.
Yeah. Or a 3-part fracture dislocation, the subscap gets pulled off or something like that. There's nothing in the front. So, okay. And then Hobie, you talked about the pitfalls of this, I think, specifically with getting the humeral head out. What do you do with these when you get a CTA and the artery is right there?
Yeah. So it doesn't happen that often, thankfully. If that's the case, I let one of the vascular surgeons that's hanging around the operating room know about it, let them know what is going on and what I'm doing. And then I very slowly and very carefully get in there, figure out how to kind of manipulate the head around the soft tissue so I can get this thing out. It's a very long, laborious, slow, difficult process. It is not without some angst. I've only had, a handful of these that I had to get the humeral head out of a dislocated position like that. But I think if you know it's close to the vessel, talk to your vascular surgeon, have them around, like, hey, this is going on. If you want to come have a peek and help me, that would be even great, better. Yeah, I just make sure that people know. And then it's just a time-consuming thing to get a good look. Make sure you know what you're moving. Make sure you know what you're touching when you're trying to get the head out of there.
Yeah, I totally agree. Typically my vascular surgeons, they just tell me to shoo off and they say, yeah, we're around, just cry for help if you need help. But I think if you are palpating around there gently, you'll feel the artery. And then I tend to sort of use my index finger to protect the artery and then try to lift the humeral head off. But I think seeing it if possible and visualizing it if possible is the most important thing. So, okay, I'm going to go into this is sort of my approach, and then we can see if there's anything different. So I do delta pec for all of these. The difference between delta pec for fracture dislocation versus a anatomic total shoulder is that it's all, there's a hematoma, the tissue is traumatized. And so it's a lot more difficult to get the planes, but I think taking your time, finding the vein, I center my incision just medial to the coracoid and go down towards the deltoid insertion, kind of dissect down, find the vein, lift the deltoid laterally, and then typically there's a lot of destruction already. I open the clypectoral fascia, and then I just tag the tuberosities if I can see them. And then if the tuberosities are fractured, like in a 4-part, then I peel them. One medial, so the lesser tuberosity goes medial, the greater tuberosity goes lateral, and then through the intertuberosity sort of groove, you're able to get into the joint. And it's at that point that usually the joint is empty. And so I will go and palpate the axillary nerve if I can find it, and then I'll do a capsule release around the lesser tuberosity, the subscapularis, and then usually the head is has torn through the capsule and gets buttonholed down through and inferiorly. So if you release that capsule very carefully, knowing where the axillary nerve is, then everything opens up and you're able to go down and get it. I will use various different instruments to go and get the head, either a shank pin, so you can use a 2.5 millimeter shank pin to go down into there, or a bone hook, coker, if you can grab it if you know you're not going to fix it, or sometimes just my finger or a cob. There's lots of different instruments. I think you showed that well in your talk, Hobie. Just have a lot of different options for reducing, but same thing for going to get the humeral head out. And then once the humeral head is removed, typically has no soft tissue attachments on it. And so I will just then proceed with the reverse. So you can see here, I put retractors around the glenoid. Because there's no humeral head, you typically get excellent glenoid exposure. And then I'll do the glenosphere, so the definitive treatment or definitive implant on the glenosphere. And I will lateralize slightly and get the implant nice and low. And then I will do a trial with the stem to make sure I like the height. I know there's a question about this in the chat. But I think for me, typically it depends really on the impaction or the comminution at the neck and where that fracture goes through. So for this one, I like to just get a stable stem. I get the stem in the right position, and then stable at that neck, and then I'll take an X-ray and I look at where the tuberosities go, and if the tuberosities seem like they're well aligned. This is an inset type of implant, but there's obviously different implants. So you just have to know the implant that you're using, and that height. There's different different descriptions of it: 4 centimeters, 5 centimeters from there. But I think it very much depends on mostly center of rotation. So I will reduce it and see if it's stable, and look at the tuberosities, and then try to figure out if the humeral head is at the correct height in that way. Dan, do you have any other tricks for reverse determining the height?
Yeah, I find that with any Hemi or reverse, you're really, if you have the calcar intact, i.e. the Shenton's arc goes nicely up that arch, like in the X-ray that you have, you can actually see Shenton's arc kind of starting. You have the curve that in medial calcar. Exactly. And what happens is that the implant, if you actually sit it on that as it's flaring, it's almost always correct. If you look at majority of the humeral head cuts that we do, it's around that location. The only problem is if you have calcar involvement in your fracture. And in those situations, I've actually retained it, and I've actually used it as a key to see what that height is. While we talk about pec major and reference to pec major, I find that overall it's not as reliable in my hands when I do it. And I found that really trying to find that medial calcar and sitting the implant on that is you're going to get pretty close to that. And then I also reduce the tuberosities, and that's a very good indication. Oftentimes it's not that comminuted, and the lateral cortex you can kind of see and piece it together. And then if you determine the reduction, you can actually get the height of the tuberosity, in which case you'll know exactly where the implant will go as well. And one other question that came up was just trying to get that head out. You can, as Jonah mentioned, you can do a conjoint or coracoid release. But oftentimes if you have that spider, and this is where it's really handy, if you forward elevate, it takes a tension off the conjoint, and it really relaxes it and puts the shaft to the back. So it's a little bit easier to retrieve the head.
Yeah, definitely. And also flexing the elbow up will also help reduce or release the biceps a little bit. So that helps as well. Okay, Diane, are you fixing tuberosities or repairing tuberosities on all of these, some of these?
I am, for sure. I know that, you think it's a reverse, and this is the one situation where you don't have to worry about the cuff, but unfortunately we only have 2 external rotators. So you really do have to repair the posterior tuberosity to maintain remnants of infra teres minor. And so I always do the suture reconstruction to the shaft, to the implant, and try to get them to the front to subscap and the lesser as well. And oftentimes if I feel that it's a large enough fragment and I want better stability, I'll have a very low threshold to even put a small plate on to give it some added fixation. But for sure, the tuberosities for me is a must.
I saw you present that at a meeting like a few years ago, and we had started doing that before, but it's just nice to know that other people that we weren't crazy for doing it. So I really like it. I think it's a great idea. I fix all of these because the literature shows that they do better forward elevation when they heal, and also external rotation. So I think for both cases, I don't have a lot of time left for this case, so I'm just going to go through my technique. But I basically place shuttle stitches around the greater when the trial is out. So I put the trial in, get the X-ray, check it, and then this is where I replace my tag stitch with shuttle stitches, and then I put stitches through the humerus and then also through the implant. And then I impact the definitive implant down, place some bone graft around underneath where the tuberosities are going to go. And then I pass the shuttle stitches, or using the shuttle stitches, I pass the tape suture through there. And that allows me to shuttle them after the implant is in. It's just a lot easier. I used to place all of these after, or pass them through after the stem was down, and it's just such a pain to get around. So doing it this way with the shuttle stitch is actually quite beneficial to me. And so here's the tuberosity repair. I think you should leave with it stable. So I'm forward elevating and externally rotating. You can see there's no motion of the tuberosities at the plate or at interface with the implant. I do use local TXA and vancomycin, but I think otherwise it's just pretty standard. So here's what it looks like at the end. You could maybe say I over-reduced this a little bit, so maybe my knots were a little bit too strong, but otherwise everything else is sort of in the right position. And that leads us to another question, which was, where's the place of Hemi? And so here's a 48-year-old patient who fell off at high energy at work, and he's now sort of 8 days out after being at another hospital. And Hobie, what do you think the survivability of that head is at 8 days?
Unfortunately, probably 0.
Yeah.
It would be nice to get him on day 1. So if I got him on day 1, I would fix that. I would try to put that together. I would try to get that to survive. 8 days, I don't think so.
Yeah, I agree with you, Diane. Would you fix this on day 1?
Yep.
Yeah, I agree. I think I try to fix these on day 1, but at this point, for me, I think the cat's sort of out of the bag, and so I just move on to a Hemi. Now, because he's 48, I wouldn't really consider a reverse, and I think a Hemi arthroplasty is probably the best determinant. So some of the key points for Hemi arthroplasty for me are really, I try to size it off of the pec major, especially if there's comminution in the greater tuberosity, because typically when I do a arthroplasty, I do release the pec major at least about 1 centimeter. For Hemis, I specifically do not release it because I think it's important. Then I take the humeral head fragment out, and then I'll use that to size. And then typically I will undersize by 1 thickness. And so it's important that you want to recreate the center of rotation. And so you can see here, center of rotations can be right in the middle, right where that head is. And then you want to fix the tuberosities stably. So the things for, fixing the tuberosities, you really want to make sure you have some sort of vertical and some sort of horizontal fixation. You don't want to over-reduce. And I think if I want to be critical of my case here, for the trial, we had it in the right spot, but then I guess, again, when we're tying the knots, we did over-reduce a little bit. Maybe more bone graft would have been helpful for this one. So you see, I can kind of draw it where it should go. And I think adding a plate and screws to the lateral portion of the grater is very helpful. And so typically I will use a mini Fragment 2-4 plate, T-plate with locking screws if needed distally around the stem, and then just some screws up in the proximal aspect. I'll also use a suture through the plate, so sort of doubling down, but it gives it that extra bit of rotational stability. And so here he is at 2.5 years. He's healed. He actually has really good motion, and he's nice and centered, so you can see the cuff healed nicely. And that's it. I did see a couple questions about cement versus no cement. I typically don't use cement unless the patients have absolutely no stability with the trial, because then you need some sort of rotational stability, so I'll be able to do that. And I typically do not use a convertible stem for Hemi because the center of rotation for a total and the center of rotation for a reverse are very different. And there is only one stem on the market that I know of where you can convert the body, but typically most convertible stems are not, they're onlay, and so they're not ideal to recreate the stem, right? So you're sort of the worst of both worlds. You're making it a less good of a Hemi and then a less good of a reverse. So that's typically what I do.
Yeah, so for me, I try to use a platform system whenever I can. A lot of the systems do allow for a Hemi that will go electively. So I've kind of moved away from using fracture stems, one, because the length is a bit long. I don't think we have to use long stems anymore. The technology has gotten better on the humeral side as well. And I find that in the times that I've used a convertible system, when I go back on a Hemi to do a reverse, I typically don't have any problems on soft tissue balance, and it'll take a tray that's a reverse tray. So it'll be, oh, I can make it a 145 or a 155. So there is some modularity, but I think you have to know your implant system quite well in order to do that. So it takes a little bit of homework if you're going to use that kind of a system. That being said, converting a Hemi to a reverse, if you're cementing the stem, which we sometimes do, it's a tough to remove that. So I think I do it more for that reason, to just save the headache of trying to rip out a well-fixed stem. Okay,
so one other question about TXA irrigation. I use IV for elective total joints, but I do use local for trauma, just because I find that it tends to work a little bit better. And there's a couple of papers, including the one that won the NEAR study a few years ago, or the NEAR award. It's 2 grams of tranexamic acid in 60 cc's of normal saline, and I just inject, or just put that into the wound as I'm getting the x-ray. So it has about 5 minutes to stay in there.
Okay. Now I just had some, can you see my screen now?
No.
No, not yet. Okay, let me just, okay. Can you see it now?
Yes.
Okay, great. So, you know, it's such a big topic, and it's such a great discussion that we're having. I wish we could talk about it for another hour, but we just wanted to highlight some of the key points on the 2 techniques. And when we think about them, I think the literature gives us a lot of options right now. And one of the things that we wanted to talk about was a paper done in 2020 in JBJS regarding the comparison of a reverse total shoulder and an Orif. This was a level 1 study, a multi-center randomized trial, and it was a single blinded procedure. The therapists that were assessing function and doing the measurements were completely blinded. And, you know, the results were actually very promising, but I think with any literature that we have to kind of critically appraise it. And when this was published, it was basically really good for us, because it gave us some direction on something that we were already observing when it came to reverse total shoulders. We knew personally how much better our patients were doing earlier on, but we really didn't know head to head how that would do. Now, in terms of the actual results of the trial, they looked at the primary outcome as being the constant score, and their age group was really the elderly population between 65 and 85. And they actually were very careful in delineating the exact type of fracture pattern. So these weren't all proximal humerus fractures. These were the B2 types, which is the multi-part involving lesser and greater, whether extra-articular, or the C2 type at the anatomic neck, so intracapsular. So these ones were very displaced, and the requirement on the inclusion criteria that was significant angulation displacement with greater than 45 degrees. And, you know, a lot of the patients that weren't eligible were because they weren't displaced enough. So I think they took those cases where we are already thinking about surgery. It's not one for non-operative, and then trying to choose between an open reduction or an arthroplasty. And as our topic is, you know, a lot of us don't go the arthroplasty route because we don't have a lot of experience with it. We can manage the fractures and fix them, but doing the arthroplasty is somewhat more challenging. I mentioned you have to really know your implant system as well in order to be able to, you know, customize it for your patient. And that's something that not all trauma surgeons or fracture surgeons do. In this study, they had, by the end of the day, they had about 60 in the Orif and 64 in the reverse. And really the key point from this was that, you know, again, the crux being at the 2-year follow-up, which is fine for fixing, but not quite long enough for arthroplasty, is that the data suggested that the reverse total shoulder was better than the fixation group in these subclass of fractures in this elderly population. Now, so I just wanted to open it up to our presenters. You know, when you think about this study, Joan, I'll ask you first. How has it impacted the way you practice? Are you actually using the study and applying it every day?
I don't know, every day. I think to me it confirms sort of what I may or may not have already been doing, in the sense that I think that the reverse for fracture is a very good surgery, and it gives people very good outcomes. And it gives me another reason when presenting this to patients, saying we have good literature to back this up now, that you will likely at 2 years do quite well, especially if tuberosities heal, and definitely if we avoid any complications. And then, you know, I use this plus other literature to kind of back my statements up with, this is typically what our complication rate is. This is what my personal complication rate is. And if we avoid that, then you'll do quite well, and probably better than if we fix. Long term, we don't know. But yeah, I do use it, not necessarily specifically, but as part of sort of all of the, you know, information that I try to give to them. I will definitely use that.
So Hobie, like taking that case I just showed, and I know you're a trauma surgeon, you fix a lot of these. When you look at the literature, is this something that you're now just going to say, well, okay, the literature says I shouldn't fix this, I should probably just pass it on to one of my arthroplasty surgeons? What's your take?
Yeah, so I think for the anatomic neck fractures, where the humeral head fragment really is quite small, it's, you know, you have this kind of sliver of humeral head, I think is different than the surgical neck fracture, where you have a bigger piece of head. So I take it with a little bit of a grain of salt. However, I think that as much as I love fixing these, and as much as I like to think my patients do well, I think that the role for arthroplasty is increasing, and I think they're improving people's outcomes. So for me, if it's changed anything, I spend more time, I think, talking with my arthroplasty partners about these fractures and kind of figuring some of these things out together. But I think there is a little bit of difference between surgical neck and anatomic neck when it comes to fixing versus replacing, at least in my mind still.
Jonah, so is this an arthroplasty for you? You don't even have to think about it?
Yeah.
It's 60 something, 65. I forget the age of the patient, but yeah, to me, this is, if I'm going to offer operative management, that means the patient medically can withstand surgery and all this, then I'm going to do arthroplasty, and it'll be a reverse shoulder for me 100% of the time.
This is one that I look at and I'm like, okay, am I going to be able to obtain and maintain a good reduction such that they can begin doing therapy early on with that fracture? I don't think I can. So I would agree with Jonah.
So when I had a look at this fracture, this is one of my patients, I had the same kind of idea, and this is before I had read the RCT paper. And I think even in my own practice, I found that I was having a lower threshold to actually do an arthroplasty. The higher the age, the more fragmented, angulated the fracture or displaced. I was getting, pretty much into that mode where I was considering arthroplasty a lot more. And, I love fixing fractures and proximal humerus fractures. I think with the techniques that Hobie mentioned, I think you can do a very good job, and these usually heal well. And the tuberosities do heal when you pay attention to them. So that's a successful operation when done well. But I think that's the thing. When anything is done well, I think you're going to have different outcomes. You're going to have reasonable outcomes than anything else. So this study doesn't really look at that particular aspect, right? We're talking about shoulder surgeons, actually, because in this study, the shoulder surgeon did the fixing and the replacing. So you know that they were shoulder surgeons to some degree. So again, they may have an additional skill set that the general orthopedic surgeon may not. So I think the technical aspects, as well as with the experience that you have, really impact not just the study saying that we should do that, but it really the finer parts of the technical bits are really important. So for this patient, I did choose to do an arthroplasty for those reasons. And I think if you can do a good arthroplasty, you can reduce the tuberosities, you can get good alignment, and you can get longevity out of this implant in the right age category. And as Jonah mentioned, it's one operation, and you don't have to have that concern where the screws may cut out, or you may have secondary complications from that. Now, if you think about that fracture and this fracture, it's a little bit different. And again, if I gave you this fracture, Jonah, what's your take on it? Would you apply any of the literature on this, or use your own experience?
Yeah, I mean, I think to me, this, although it looks like a 3-part fracture, I would probably get a CT scan because that's how I do this. But it behaves much more like the second type of fracture that Hobie was talking about, right? The large humeral head piece, essentially like a glorified 2-part fracture that I can manipulate and fix. And to me, even though the literature, would discuss about the options of a reverse doing better than fracture fixation, I would definitely talk to the patient, say, okay, if I think there's a reasonable rate that this can heal without avascular necrosis with minimal complications, and you fix it, and it, typically, I think that that's probably preferable.
Even if they're 84?
I would definitely discuss it with them and offer it to them. Yeah. I know. It's still like heresy. Half of my shoulder surgeon side is sort of saying this is crazy, but I think, if you know how to fix these and you can get good reduction and stable fixation, then I think this can do well. This is not the classic sort of small head fragment that benefits grossly from having an arthroplasty.
Can I ask you how many times you've gone in thinking you were going to fix it, and you'd had to, what you saw during surgery changed your mind? Was one of the questions as well from the Q&A.
I'll be honest, like 0, but that's because I get CTs and I have a really good discussion with the patient and myself, and we decide on a reverse. I do a reverse. If I'm going to fix it, I fix it, and I kind of very, very, very rarely would change intraoperatively.
Now, the study did have a standardized protocol. I would ask, what's your protocol for arthroplasty? And Hobie, what's your protocol for Orif? For rehab?
For rehab protocol. Is that what you're asking me, Diane?
Mm-hmm. Yeah, it's one of the questions.
Yeah. So for rehab, it depends on the fracture pattern, right? So it depends on the patient. It depends on how well I can reduce it, how well I can fix it. But in general, I think you should leave the operating room if you fix these and be able to begin pendulums and some passive range of motion immediately. I do that right away. And then it's a matter of, okay, if I don't have tuberosity fractures and it's a 2-part fracture, I'll begin active range of motion immediately. If I have a very simple tuberosity fracture, it's a nice big piece, I can fix it really well. They may do pendulums and passive for 10 to 14 days, and then I start doing active range of motion. If I have a more complicated, the greater tuberosity is a shell, the lesser is also broken off, and I have to fix it with a screw, then I may have them do passive and pendulums for 3 or 4 weeks, and then I start doing active. So it really depends on their pattern, like how I progress them along, but I keep them moving. These are people that I don't see them for a post-op visit and then see them 6 weeks later. I've seen these people every week or 2 in my office and progressing them.
Hobie, what about for the arthroplasties? Sorry,
yeah.
Jonah. Yeah.
That's okay. Typically, because I fix all tuberosities, I usually shut them down for active for 4 weeks. So I'll put them in a sling for 2 weeks, let the wounds heal, and then I start them on some gentle passive motion, forward elevation, passive, and some mostly waist level stuff. And then at 4 weeks, I have them start active gently. And then by the 6-week mark, they can start increasing more and more. I only start strengthening at about 12 weeks. I leave mine in a sling for 2 weeks full time, and then 2 extra weeks part time, sort of as they can kind of wean out of it once they're at home and not doing too much. I try to limit internal rotation for 6 weeks, mostly for dislocation fears. But other than that, they start going.
If I could add one more thing to my rehab protocol, I think when people first start doing active motion, when they do it standing or seated, they're really fighting gravity and they really struggle. So I specifically write on their therapy order that I want them to do active range of motion in the supine position. I think it's extremely helpful for them. They can move further because they're not fighting gravity. It's more comfortable. I found that to be a very helpful thing too.
Great. So, I think there's so much we could talk about with the rehab. I mean, my rehab's very different as well. It's similar but different. And I think everybody has learned to kind of figure out how to move patients sooner. And I think probably that's the key. During surgery, what you want to achieve is to get the most stable fixation or an implant there so that you can really facilitate that rehab protocol, so to get them moving as fast as you can. So really, from the paper, I felt that, again, great literature. It helps us to go in the right direction, but we didn't want to make it general. Don't conclude that, a reverse TSA is better than fixing for proximal humerus fractures. That's not what the study was trying to intend. And I think we do have to always see the details within the work that's being done. It's really specifically for displaced anatomic neck fractures with lesser and greater tuberosity involvement. That really gives you at the 2-year mark that reverse is showing better outcomes than the fixation group. And of course, with any of these studies, you just have to really read it in detail and make sure that you individualize it, not only for your patient, but also within what you feel is comfortable in your hands. So just to finish off the evening, I just wanted Hopi to go over some of his pearls on Orif, and then Jonah, you can tell us your pearls on the last little bits that you want to leave with the participants.
Okay, so my kind of summary slide. I think if you're going to do open reduction internal fixation for these fractures, you really need to have a step-by-step approach. Figure out what surgical approach you're going to use, learn how to master these approaches, figure out which patterns you choose to do whatever approach you want, but really get good at your approach. I think getting sutures in the cuff is paramount, and I do that first. That's one of the first things I do, is get sutures in the cuff tendons. Check out the bicep tendon. So there's, and I know we could probably argue for another hour whether or not you tenotomize the bicep, what you do with the bicep tendon. For me, in young people, if the lesser is intact, I try to leave their bicep tendon if it looks good. In older folks, I'm more likely to take it down, but that should be part of your step when you do the cuff sutures, evaluate the bicep tendon. I think the next step, once you have all that done, the head shaft reduction and provisional fixation is key. That's the next step. You have to do that. You can't fit your tuberosities in position if the head shaft reduction isn't adequate. Assess for augmentation needs. You may need some augmentation, and then getting your plate position, getting your sutures for the cuff through the plate, figuring out the height of your plate, where your calcar screws are. That whole plate positioning thing may take 15, 20 minutes to get it right. Like, it's a really important part of the case. Fixation for me is typically to the shaft first, get my plate so it won't move. When you do that, assess the translation of the shaft relative to the head. You get your head shaft reduction nicely. You don't want to put in non-locking screws and then over-lateralize the shaft and ruin everything you've done. And then tie off the sutures for the cuff, and I always consider a screw for the lesser tuberosity.
Great, thanks so much, Hopi. Jonah, what are your take-home messages?
Let me see here. Is that working?
Yep.
Okay, so my indications for reverse fracture are 60 and above. I usually do 3-4 part, mostly 4-part, with or without dislocations. Thin head fragments, we talked about medial calcar comminution. My indications for Hemi arthroplasty are limited, I would say, at this point, not necessarily because I'm right, but just because that's how I feel. I think it is a harder operation to do, and I'd much rather fix the younger patients as much as possible unless there is a extreme risk of AVN. And how to calculate that exactly, I can't give numbers. There are some keys, to identifying those patients, and so those are the ones that end up with arthroplasty, hemi arthroplasty for me. I repair tuberosities in every single patient, at least attempt to repair. Sometimes it's more of, like I said, a cloud of bone rather than an actual tuberosity, but I still think you can repair it. I bone graft these, and the most important thing is to get stable fixation. So I get sutures going this way and going this way around the lesser and the greater, going to the humeral shaft, going to the stem, and that's my protocol. And then my algorithm for fixing or replacing or treating these fractures is really for 2 parts. Most of these patients are non-operative, especially the older patients. Some of the younger patients are also non-operative. Again, non-operative doesn't mean non-interventional, right? So I have these patients do active rehab early, as early as possible, so they can get moving again. For the older patients, it's rare, but I will sometimes do open reduction to a fixation. And for the younger patients, displaced fractures, or very displaced fractures, will get ORIF, and that's typically it for 2 parts. For 3, 4, and parts and fracture dislocations, in patients above 60, almost exclusively they will end up with reverse shoulder arthroplasty, or I didn't put it because it may be sort of heresy, but non-operative management, right? So patients that are medically precluded from having surgery, you can treat non-operatively. Their outcomes are not as good, but they can still do okay. And then in younger patients, usually fix, very occasionally Hemi, and that's sort of my algorithm. I did see a question in the chat about how I position the arm positioner. I think supine, you put it at right about the shin of the patient, with the arm going up towards the patient, the mechanical arm. And then I have the patient's arm in it and forward flexed about 70 or 80 degrees up in the air, 70 degrees probably. And then you can move the arm out laterally to get your axillary view for imaging, and it can all be done with the arm in the same positioner. Typically what I do is I put it on before, do x-rays prior to draping and prepping, and make sure that the radiology tech see how to get them, and usually that works. So that's it.
Great, thanks so much. So just to wrap things up, I really appreciate everybody's attention, for this session. I know I've really enjoyed speaking with my presenters, and really appreciate all the questions that we got. These are key questions that come up. And I think, if you have any further questions, please feel free to email us at the contacts. We're on the website, and I'm happy to provide that as here on the Q&A as well. Remember, the upcoming sessions is going to be next on June 24th. It's on humeral shaft fractures, MEPO plating, IM nails, and Orif. I know there were some questions in the Q&A regarding IM nail and indications, so I think that's definitely one that you might want to sign into. And of course, there's proximal femur fracture revisions up on the 31st, and geriatric distal femur fracture is the last one, the last hurrah on June the 7th. Please sign in for that one. And if you've missed any of part of the lectures today, or you want to revisit any of them, please check on the AO Trauma North America YouTube site. All of the recordings are there, and you can view them at any time. So again, thank you so much for joining us, and hope to see you soon at the next Fireside.